Introduce you. Welcome back for this afternoon. I have actually the great distinct honor of introducing this gentleman next to me, Dr. Jerry Bouquot. Now I have to read a paragraph, which is kind of funny because I asked him for his resume one time, his CV, 34 pages. I think it's longer than that. So that would be the entire time for his lecture to be able to give you some of the credentials and some of the information that Jerry has given to people around the world. He is respected all around the entire universe, including Earth, by those people who want to know the truth. Jerry is a professor and chair of the Department of Diagnostic Studies at the University of Texas Dental Branch in Houston. I went to San Antonio. That was our competition. He is also adjunct professor of West Virginia University School of Dentistry, where I believe he held the chair for oral pathology for approximately 17 years. See? It's not written. I remember these things. He is a co-author of the most popular textbook of oral pathology used in English-speaking countries. Is it translated into Spanish yet? Portuguese. I was close. He presents more research and continuing education seminars worldwide than any other oral pathologist in the world. He has brought cavitations and dangers of root canals to the forefront in pathology and has been our biggest advocate. And I just want to thank Jerry personally for everything that he has done for myself and my colleagues. And the amount of arrows pointed his way, as Hal was talking about crosshairs, is amazing. This man has tolerated, been put up with, and has survived the onslaught of insurance companies and big money to present the truth, and he doesn't veer away from it. My pleasure to introduce Dr. Jerry Bouquot.
Thank you. Well, I wanted to point out that I'm not going to talk about Nico today. But, yeah, I did want to point out that it's really odd. Chris and I were just talking about that at supper last night, that I am the only oral pathologist who's been interested enough in bone that after his residency, he spent a year in the Mayo Clinic, actually, is where I went. But it was a year of bone pathology fellowship. And it just happened to be under David Darlene. I know you don't know him, but in pathology circles, he was like the dominant force in bone pathology during the last century. So it was very interesting that I would be the one person who would go to West Virginia, where one of the only oral surgeon that I knew of at the time was treating these lesions, and he was about 45 minutes down the road. And just to make things really more intriguing, is I was the oral path consultant for our state licensing board, and they tried to take his license away after treating people for about 30 plus years. So I was forced to look at his cases. What are the chances of all those happening together? It's pretty strange. I have to admit, there was a time when I was young. Things have happened. I went to Houston, and I couldn't get a yay or nay from the University of Texas about what to do with my biopsy service. In West Virginia, it was one of the 5 or 6 largest in the country. And after 2 years, I just gave up and gave my biopsy service to the University of Texas so that my wife, who was running the business out of West Virginia and FedExing slides every day, could come down to live with me again. And but during that 2 years, I was eating out. There are lots of nice restaurants in Houston, and I put on like 40 pounds in 2 years. And now I'm trying to lose all that. One of the awards I'm most proud of is back in 2008, the American Academy of Oral Medicine gave me a bottle of Geritol. It's just to let me know that I'm not getting any younger. And I always wanted a motorcycle, but this is sort of my biker bar nowadays. One of the odd things about the internet was that I typed in my name to make sure that the national address book had my proper address. And I found out there were 3 Jerry Bouquots, and they had different addresses. And 2 of them were in Arizona, and I have a brother in Phoenix. So when I was visiting my brother, Randy, we stopped to see Jerry Bouquot and Jerry Bouquot. And this is Jerry Bouquot. And it turns out my great-grandfather, when he grew up from Tennessee, he went up to Minnesota, and there were nothing but Lutheran women to marry. So my whole family is all Lutheran. This guy is French Catholic, and his whole family moved over through Texas and into California and dropped off little families here and there, and they pronounced their name Bouquot. So he's Jerry Bouquot, and I'm Jerry Bouquot, which isn't the correct French. But I'm Swedish anyway, so who cares? When I was trained in Minnesota, it was the premier place in the history of oral pathology to be trained. We had 10 board-certified oral pathologists. Bob Gorlin was the chair of that department at that time. And he's been written up as one of the 5 most influential dentists of the last century. Just a phenomenal man. I went to his memorial service. Nobody talked about his genius, the 800 papers he wrote, the 5 books that he wrote, 3 of which became bestsellers in their fields, or the Bible in their field. They all talked about what a kind heart he had and how he always cared about other people. It was really a phenomenal experience to hear a memorial service like that about a guy who literally was a genius with a photographic memory. But I went from there to West Virginia, really thinking it'll be fun. I've never been in the mountains. It's a brand new school, only 9 years old at that time. And everybody I met when I interviewed was really friendly. And it turned out that was a correct assessment. So I went to West Virginia thinking I'll be here for 2 or 3 years. I got a call to come back to Minnesota. And I just had already fallen in love with those mountains. So I stayed in West Virginia a total of 30 years. And then a friend of mine became the dean in Houston and asked me to come down to interview. And as a favor, I did that. And my family said, you need to be around students again, because I was in private practice at that time. So that's why I've been in Houston about 7.5, 8 years now. But can you imagine this compared to West Virginia? West Virginia, I lived in a town of 28,000 people. There are like 4 times that amount in this city during the daytime. It is now the 12th largest city, if you want to call it that, in square footage of office space as well as population. And I thought I really couldn't adapt, but it's been a lot of fun. I've gotten to know people all over this campus. MD Anderson Cancer Center is right next door to us, and we have a really good cooperative experience with them. I actually give one-on-one training to their head and neck pathology resident for a month every year. But we've got a couple of medical schools. We've got 3 nursing schools. We have 1 dental school right in the middle. And as it turns out, this whole concept of a Texas Medical Center was started by the dean of the dental school. He was good friends with MD Anderson, which was a tiny little hospital at the time. And in the 40s and early 50s, they worked with the state legislature to make this into a medical center. And it's a phenomenal place. Really, I like it. I didn't think I would, but I do. I've been chairman of this department. We just changed our name from Department of Diagnostic Sciences to Diagnostic and Biomedical Sciences. We have 39 faculty. Half of them are PhDs. We have 3 PhD candidates. And we run assessment, treatment planning, and imaging center, which is mostly radiology in our place. We've got a that wasn't so good. I have no idea what button I pushed for that. We have a biopsy service that we lost a few, maybe a third of the business when I moved to Texas, but it's still one of the largest in the country. And we have lots of different services. We're one of the few immunofluorescence labs in the country in the dental profession. And we have people that are really busy. We give 56 courses. We had 81 publications last year. There are 35 research grants in the department. So I went from a department of 2, 3, or 4 people to this. and had to instantly hit the ground running. And for literally 3 years, I could do no research of my own at all. And now I'm getting back into that and just in time to retire. This was a medical center on top of a hill in West Virginia. It's mostly under one building. I'll be retiring next summer, going back to my little mountains, getting some seasons again. And I just wanted to show that's where I'll be living, right in the firewood. Back in the early 90s, I asked one of my old students, Brad Neville, to please write a textbook. He and two of our mutual friends I knew took a lot of really good clinical pictures, and they saw a lot of patients, and I wanted a textbook that had a clinical orientation. The previous textbook, Schaefer, Hein, and Levy, many of you had in your career, was 40 years, and it was way out of date. So these guys, after 2 years, said they'll do it, but only if I help. So I'm the fourth author on it, and we've gone into 3 editions, and it's about 90% of the oral path market worldwide. It is, I mean, it's been used in court even. This is the standard of oral path. So it's been really an honor to be part of all that, but I'm getting older, and I won't be part of the 4th edition. And oral pathologists have kind of an odd sense of humor. When the book came out, we had an Oral Path Academy national meeting, and this guy whose company he calls Butt Sketch was going around sketching everybody from behind. And so he drew us while everybody was watching and hooting and hollering. And, of course, somebody started saying, bookends. These are bookends. So that became a fairly unique thing in the annals of oral pathology. It's been translated. We think of Iran as being a very suppressed country. This is a woman faculty in the dental school in Tehran, and she translated this all on her own, sent it to the publisher. That's almost never done, to translate an entire book. I mean, this is a huge book. And the publishers were so impressed they decided to publish it. I got a copy. We have a guy from Iran in my department. And so I signed the copy, and he started laughing. He said, "You don't know that Farsi reads from the back forward." So I essentially signed the back of his book. When I quit I quit academic dentistry back in '94 because we got a new dean at WVU, and I couldn't stand the guy. But I loved the mountains, so I set up a private research center and a biopsy service, and that went very, very well. But as something to do, I decided I want to learn how to do this website stuff, and I started a couple of websites in the late 90s. And I just checked last year, and this one called oralpath.com had 2.3 million hits last year. And I've checked with the company. They said they're real hits. And MF Center, which is where all the NICO stuff is designated or lies, had 3.4, almost 3.4 million hits. So my retirement is going to be to try to make these better. If so many people are watching it, there's got to be something going on. You have available Bouquot to Go, a disc that's maybe part of my legacy. I don't feel that I have to leave something behind as I get older, but who knows what's in the back of my mind. But these are just some things. The 53 most common oral lesions is, without a doubt, the most popular PowerPoint presentation in all of oral path. It's all over the world, as actually the whole Bouquot to Go thing is. C.D. Johnson collection is a bunch of pictures from our urgent care clinic, and I'll talk to you a little bit about C.D. Johnson in a moment. A lot of the pictures I'm using for this lecture, I'm going to talk about the abused mouth first, and then these devices second. But a lot of the pictures I'm using came out of his clinic. And a lot of what I know comes from him and his personal experiences. There are lots of little lists. If you get somebody with pigmentation and you want to know what drugs produce pigmentation in the mouth, I just call it Bouquot's Little Book of Lists. And it's got lists like that. So you don't have to keep it all in your head. And this has been a sort of a labor of love. I changed the name just a few weeks ago. I bought a mystery book called Troubled Bones, and I thought, that fits this NICO thing perfectly. So that'll change on the next Bouquot to Go collection. You maybe can't see this, but it's got over 1,000 pictures. And about maybe 2/3 of them are microscopic. It has lots of references. It has thousands of hyperlinks. If you want to understand things from my perspective in that field, then this, I think, will help you a lot. And there are a few other things. There's a NECA lecture that I gave and have modified a bit since, but that's the actual lecture from 2007. And this is something to help with a differential diagnosis. I call it the must-know oral lesions. It is a whole collection of pictures, and they're all according to clinical presentation. If it's a white lesion, then this is a list you should know, and it's for dental students and family dentists who, those are the lesions that I think every dentist should know about, and ischemic bone is in that category. Also on there is something I've been working on. I've been working with this ischemic bone problem for 25 years now, and I started out, this has nothing to do with the, well, maybe it is the abused mouth, I don't know. But I started out not understanding it very well. I thought it was an infection, and it is partly infection, but it's partly, there's some blood flow problem associated with that that's different from most infections in bone. So last year at the American Academy of Oral and Maxillofacial Pathology meeting, I presented my classification of microscopic classification of all these ischemic bone diseases. So if anybody is interested in that sort of thing, or you send your biopsies to me and I give you these names, that gives some explanation. And this is sort of the formatting. These are all the names that used to be called osteonecrosis, and some people call cavitation still today. It's for a microscopist, it's a whole different ballgame trying to understand all of this. And this is probably just the last point I want to make before I get into the topic is this is probably what I see more than anything else, bone marrow edema, which was a name that barely existed when I started out in this field. And bone marrow edema, I'm taking my information straight out of the medical literature, the orthopedic literature, and I'm just applying it to dentistry. So all of the names might be a little bit different from the regular literature, but most of these terms are taken out of orthopedics. And as with every seminar I've given since Dr. Gorlin died, this is Dr. Pinborg. I'm dedicating it to these two great human beings. Well, let's look at this. I only got involved in this because C.D. Johnson, the head of our urgent care clinic, decided that I needed to know a little bit more about this. C.D. Johnson is a person who is really persistent. He's one of the biggest or greatest BSers I know, and that's what made our understanding of oral effects of drugs really bubble up to the surface, because he could get these patients, about 40% of the patients in urgent care are addicted to something. And if you look outside our dental school in the morning, you'll see 40 or 50 people lining up for urgent care, 5:30, 6 o'clock in the morning. He can get these people to tell them what street corner they get their cocaine from. It's just amazing what he can get so much out of these people. They just trust him, and we're talking about an open bay. I mean, the walls are only 4.5 feet high, so somebody next door can be hearing. And these people tell him their entire life story. And because of that, we were able to add a few things to the literature about the oral effects of drugs. And this is not anything new. We've been talking for yesterday and today about sort of the mouth effect on the bodies, and now the lecture is going to be more on the body's effect on the mouth, and a little bit of systemic problems associated with drugs. But in oral pathology, we've constantly been talking about this drug interaction, not the drug interaction, but the body-mouth interaction, as long as I've been around, and as long as oral pathology textbooks have been around. The first one was in 1848, and half of it was about how the body reacts to what's going on in the mouth and vice versa. So it's not a new thing for oral pathologists. These are the kinds of things I'm going to talk about. I'm going to probably go over into the second hour for maybe 10 or 15 minutes because I had my introduction here. But we'll see how far we can get. One of the things that's strange is this whole business of addiction. I don't know if you know this, but the U.S. government has just classified heavy drinkers as For males, two drinks a night, an average of 2 drinks a night. For females, 1 drink. Now you go to your doctor and your doctor will say, well, have a couple of glasses of wine at night. It'll make you healthier. And the federal government, for its studies now, is defining that as heavy drinking. So we got a real dichotomy going on right now. But typically, addiction is defined as behavior. If you have to have it all the time, if you can't go a day without a certain product or a certain doing something, then that's probably the key to addiction. This is very key too. You're always preoccupied with effects, with sources, your next use. This was a woman who was, I believe she was methamphetamine addicted. She came into urgent care with an abscess, a little bit of drainage, but her source of cocaine had left Houston and she didn't know anybody else. So she drove to Las Vegas. That's where her source had gone to. And she worked in Las Vegas. I didn't ask her what she worked at, but she got enough money to build up a little stash, and then she brought that back to Houston until she could find another source in Houston. The whole time, this thing is getting bigger and draining, and she just put a Band-Aid over it. She knew that it was destroying much of her face. She just didn't care. It was more important to find out where she could get cocaine for the next day. So that's something. Maybe alcohol is the biggest addiction in this country. And, you know, if you go to another place, first thing you do after you land is look for a bottle of whiskey, or whatever your favorite alcohol is. That's defined as addiction. That's not just heavy drinking. That's, you need this product. Another is it's very compulsive. You know that this is bad for you. Cigarette smoking is perfect. Everybody knows cigarettes are bad for you. And yet we continue to smoke. And also you can have periods of abstinence, and then you get back right on the habit very, very quickly. There are people who crave, when they stop a habit, cocaine, alcohol, cigarettes, whatever, they crave it every day for the rest of their lives. That really isn't necessarily part of an addiction. That is just, the craving itself is not part of it, but if they give into that craving and get back on the habit, it's just they start right where they left off. So these are kind of the definitions of addiction right now. And of course, you all know that abuse, we have abuse going on quite a bit in this country. And this is not today, I'm not giving a sermon or anything. I'm just trying to give you some interesting facts. One of the problems with any drug that's used for a long period of time, prescribed or otherwise, is you build up a tolerance. And you have to get higher and higher doses, and after a while, the dose that you've got is such that maybe is doing a fair amount of damage to you. And abuse is something that's a little differently defined now than it used to be as well. You can be a binge drinker in college, and studies show that binge drinkers go on to become alcoholics. But being a binge drinker is not abusing alcohol. It's just a way of handling alcohol. Abuse of alcohol has to be a routine, daily kind of affair. And of course, withdrawal, we used to think physical withdrawal symptoms were much less severe than the physical ones, but that is no longer considered to be true. Psychological withdrawal patterns are just as bad for the person as the physical. And of course, we get a lot of chemical dependency, and there are some genetic components to that. Alcohol is kind of a good, there's so much that's been studied about alcohol abuse that it's a good place to gather little figures from. But there is a gene in certain populations, large populations, and if that gene is missing, I forget now the name of the gene even, this has been known for about maybe 10 years. If that is missing, then those people can't process alcohol well enough. And if they start drinking, then they keep craving more alcohol because they want it to get into their blood, and they can't process it. It can't get into the brain, I guess, in a large enough amount. So they keep on drinking. And it turns out those populations are Irish, French, Finnish, and American Indians. And Eskimos would be, the Inuits would be part of the American Indians. And if you think about that, France has the highest alcoholism rate. It's somewhere about 18% as of a couple of years ago. We're running around 10%. But in some Indian reservations, it's a fairly poor life as well, at least financially. And some of the Indian reservations are running 33%, 40% alcoholism rates. So, and my wife is Finlander, so I know the Finns do a lot of drinking. This is one of the special problems I picked up in my reading. Teenage girls in this country, are really being hit pretty hard. If you look at accidental deaths from overdose, half of them are in this very short age period, 14 to 19 years of age. And if we look at date rapes, you would expect them to be maybe in young women, but 75% of the date rapes occur in that group. And interesting fact that I put in here just last year, I've only given this lecture maybe 4 or 5 times, but an interesting little bit of information that has come out of the real MRIs, the vascular flow type of MRIs, where they'll give a person a task and then see where the blood flow is highest. They have determined from that women or girls develop a mature decision-making process somewhere around 14, 15, 16 years of age. Boys don't hit that until 26, 27, 28. And if you think of who gets in, if you think of who gets in trouble during those age groups, it's almost never the girls. But this is one way that the girls are getting in trouble. 65% of emergency department hospital visits from adverse drug reactions are in that same group, and almost all of them, this was the first time they used the drug. It was a guy who told them they had to use the drug or should use the drug. And also, if we look at, this is about 4 or 5 years old, this data now, but if you look in high school, you see that about a third of all the high school kids have had, the question here is, have you used this product in the last 30 days? So at least a third of the high school kids all across America have used marijuana within 1 month before the survey. Vicodin is another product that's really rather strange because you, at least in this day and age, you get it from a doctor. We just had 12 doctors, physicians indicted in Houston. They were making millions of dollars each year by selling Vicodin and similar products. And so the doctors, the physicians are the source for the drug dealers in this case. Smoke tobacco, that's when people first try their smoking. If we look at the next batch of most common things, ecstasy. When you're really young, you want to have that high, that feeling of having lots of energy, and you want to go to parties that go on all night. And I think that's the ecstasy connection. And smokeless tobacco is fairly regional. West Virginia was and is still the #1 state for smokeless tobacco use. And I moved to Texas, and that turns out to be #2. And Colorado, I guess I'll have to move to next because that's #3. And if you look in 8th grade, these are people who really aren't mature enough. You all know what 8th graders are like. They're not really making very wise decisions, no matter what their gender. But 10% of them are using marijuana at that stage. And this is probably the big difference. At that age, the inhalants are the most readily available things. You can buy a super glue at any store. It's in the house, and you can inhale things, and the young kids know all about the inhalants. So there's a fairly large proportion of people who use the inhalants. There aren't very many oral problems with that, so I'm not really going to address that. But you see this tapers off, and by the time people hit 20, 21, they're not inhaling. If they're doing any drugs, they've moved on to something else. If you look at adults, these are the ones that adults are getting. Methamphetamine, I'll talk about fairly extensively. It's a very, very serious problem because it's one of these drugs you can get addicted with one use. And of course, I don't think anybody, I told you this is not a sermon, but it does a lot of damage. The United States is being accused for all the violence in Mexico right now, for example, because we're the ones who want all of these drugs, and That's what is giving. Whoa. Go there. And there just happens to be sort of like what alcohol did when we had prohibition in the 30s. It just created, since it was illegal and everybody was using it, there was an underground economy that was in play. And a lot of that became organized crime. In West Virginia, I don't know about other states, but the state government estimates that the number one cash crop is marijuana. And of course, a state like that doesn't have a lot of money, that people barter rather than use cash. So I guess that's a barter system with marijuana as well. And I'm not going to get into the systemic damage that these drugs do. I think everybody's familiar with at least some of those. The central nervous system has major problems, including comas, strokes, seizures, and convulsions, memory loss that can be very, very long-term and even forever. And Hal mentioned that a lot of the stuff that is used is right up there in the nose and very close to where the eyes are, and so we have vision damage as well. These are the kinds of things that you would expect also to affect the liver. They have to be filtered, and we only have a couple of filters. We have the liver and we have the spleen, the kidneys, and so we do get failure of those. Steatohepatitis, fatty liver, is a pretty common thing in almost every drug user, street drug user. And I'm very familiar with that because I was diagnosed by biopsy with that about 15, 20 years ago, because my lab in West Virginia had no ventilation at all, and I was in there a lot, and I got a damaged liver from all the chemicals that were in the air. If you're going to die of these things, usually it's something to do with the lungs or the heart. Especially, of course, the inhalant products are going to be affecting the lungs more than anything else. This is a neat picture that I got off of the internet. This is a syringe. They just break off the the needle, put the heroin in there, and that is essentially a suppository. It's an anal injector, it's called. And of course, heroin, cocaine, a lot of these heavy drugs have a propensity for ulceration of the entire GI system. So to put the product right there doesn't seem to be doesn't seem to be too intelligent, but that is what's happening. I won't say much about this either. A mother who's addicted to having babies, and there was a study that came out. I put a question mark back behind this last year. There was a study that said that actually there is no such thing as a crack baby. There's a fetal alcohol syndrome, but crack babies aren't affected. That's just one study, and I'll just keep the question mark there for a while. And of course, drugs, especially since all the street drugs are against the law, it creates this little artificial society. And that has changed a lot. If you go back just 20, 30 years, somebody who is into the drug culture, the heavy drugs especially, tattooing was a big part of their image. They had to have tattoos. They wanted tattoos. A lot of tattoos were put on when they were really high from the drugs, just like the sailors in World War II were pretty high with alcohol when they got their tattoos. But that's no longer true. If you look at Americans now in the 20 to 40-year age group, 1 in 3 will have a tattoo, and it's just getting more common. So the presence of a tattoo is not such a big deal now. You could have it as a gang symbol, something like this. This is somebody who definitely was into heroin. She made no bones about it. And some of the tattoos are absolutely beautiful, but I want to show you, if you have somebody with a tattoo with very wide lines, they deliberately want that because that's where they can stick their heroin in. We wouldn't have known about that except for C.D. Johnson getting them to talk. But if you have very thick lines, you can put a needle all up and down around here, and you don't show the needle marks. And, of course, there have been cultures outside the U.S. and Europe that have had tattoos. In some places in South America and Southeast Asia, the tattoo artist is one of the most revered people in those rural communities. And every once in a while, this is mostly prison tattoos. Somebody has somebody, I don't even know, I think that's a name of somebody, but fuck you is very important to have on your lower lip. That seems to be the number one tattoo that people give or have placed. And one thing I should point out, because this picture does show it, this little diastema forming from contact with this. Anybody who uses a lip barbell or lip ring, that's where you've got to make sure you evaluate more carefully than other areas. And of course, we put our own tattoos in. Hal was talking about amalgam this morning. I probably get more amalgam tattoos from inside the bone than from the soft tissue, but that's because dentists recognize amalgam tattoos and they don't biopsy them. But one of the interesting things, he mentioned that the macrophages, the histiocytes, are part of the immune system. They may not be able to handle the toxicity of certain products. Well, this is, I think, a simple physical weight. If you have a nice, tight amalgam tattoo that got there because you nicked the mucosa when you were putting an MOD amalgam in at one time, 20, 30 years later, you'll see that it's maybe 3 times bigger and the edge has lost its nice sharp margin and it's just sort of slowly fading into normal mucosa. And if you look microscopically at those kinds of amalgam tattoos, the macrophages have pulled these little big chunks of, well, to them, big chunks of metal as far as they possibly can. And they must be exhausted, I guess, at that point. So amalgam tattoos aren't necessarily stationary. Of course, sometimes you'll see them. There was a time up until fairly recently when amalgam was the apicoectomy product. You sealed the end of a tooth with amalgam, and over time that just leached out. And this is one that we put in our textbook. I couldn't figure this out, but this was a woman who flossed her teeth 3 times a day. I didn't get that from talking to her. It took a little while. Well, I did eventually get it. But she, all of her life, had had very tight contacts. Now she's got plastic in here, but she always had amalgams earlier. And she would slam that floss down into the dental papilla, and there'd be a little mild injury and a little bit of amalgam particle on the floss. And so I guess a floss snap injury would be the name for it. Oh, she's with the flossing. The comment here was she got the amalgam in there and then was transferring. She might have done it with that first molar, for example. It still has an amalgam, and then still had amalgam on the floss as she moved forward. I don't know which came first in that case. It is interesting, though, if you try to take bacteria from the premolar site here and move them over to the other side or the upper premolar site, they won't take. The bacteria in our mouth just like to be pretty much where they are. It's a very strange phenomenon. There was a very popular book about 3 years ago called My Belly Button Garden, something like that. Anybody read that? This guy found, he just cultured bacteria from belly buttons, and he found some people had as many as 80 different kinds of bacteria in their belly button, and it didn't change over time. And he tried to put other bacteria in belly buttons, and couldn't get them to take. So I guess the whole body probably has a preference for bacteria. Part of the drug culture, again, it used to be all of this jewelry in and around the mouth. That's no longer the case. As a matter of fact, I went to give a talk in Sydney, Australia about maybe 15 years ago when all this mouth jewelry was hitting the dental literature. And I gave a talk, I think it was an eco talk actually. And afterwards, the speakers were taken to this beer hall in Sydney, and we had a great time. But right across this picnic table from me was this young couple who both of them were dentists and recent grads. And I asked them, well, how? You know, I said, gee, I wanted to talk about injuries from these little baubles that people have in their mouths, and I don't have any picture. And in oral pathology, if I don't have a picture, I don't talk about it. That's just the way it is. That's why when it comes to facial pain, for example, we don't talk much about facial pain. I wrote the chapter in our textbook about the facial pain, but the other three authors didn't want to do it. They just have no interest because you can't see a change. So at any rate, I didn't have a picture, and they kind of looked at each other and smiled, and they both looked back at me and stuck their tongues out, and they both had one of these barbells, I call them, and they said, we'll send you a picture, and they did. So that was my first picture. And now, of course, I have tons of them from C.D. Johnson's collection. I haven't found a whole lot of damage from these. A lot of people have this little furrow behind, and it's smoothed out. The papillae are gone. I don't think it does any damage, and I'll show you a little bit how that happens. Well, you can see a little bit here. When they have this in their tongue, they develop a habit of taking that bottom part of the barbell and flipping it over, sometimes over the teeth, but it hits a little hard. So usually they flip it over, actually outside the lower lip, and then they slowly drag it back. And when they do that, they're moving this upper ball back and forth over this tongue. That's what it's all from. I've not run into more than, I think, 2 infections inside that fistula. And we know from other people that if you biopsy, if you remount that fistula, there is no epithelium there. It's just muscle. The epithelium does not grow down very far from the surface. So it looks like it should be a nice place for an infection, but it doesn't seem to happen very much. Yes, Chris? Yeah, Chris mentioned that some people, there are papers in the literature about abscesses. And I defended a young lady who had an endodontic case that was neglected and abscessed, and had nothing to do with the endo issue. It was a regular abscess that went to her brain, and they identified 13 different sites in her brain through MRIs, and they biopsied 2 of those, and there were oral bacteria in it. And the insurance company, because this gal is a vegetable now, she can't move, she's in a coma, and she was a college kid at that point, and the insurance company said there's never been a case of dental abscess causing brain abscess. So I went to my deposition. I literally had a 3-foot-high stack of papers that talked about that, plus some textbooks in neurology that talked about it. So yeah, that can happen. I don't know if it's the process or whether it's just lousy hygiene. These are done in tattoo parlors mostly. And until recently, well, Texas just 2 or 3 years ago said that you have to be licensed. And all of a sudden now we run a sterilizing service. We send out spore samples and take them back and analyze them, see how the sterilizers are working, the autoclaves. And all of a sudden our business went way up. And it wasn't dentists, it was all these tattoo parlors, because they had to follow state regulations. Yes? Oh, yeah, that's a whole different ballgame. I'll show you that. She's talking about damage to the anterior teeth or the gingival tissues. That is a real problem. And that's what I'm doing. I'm just showing some of the problems that can develop from these. This is somebody who demonstrated how she holds the tongue outside. And this is what you're kind of talking about. This is a pyogenic granuloma that developed, and there was really no tissue. They had to remove the entire thing, and there was a nice diastema in that site. You can also chip the top of the teeth with that lower part of the barbell. And I've had a few people, here's one of them, that had a little pyogenic granuloma, if you will, a granulation tissue develop around the very opening. We have people in Houston. They wouldn't allow us, 2 of them now, they wouldn't allow us to take their pictures, but they took a knife and cut their own tongues in half. And one of them had developed to the point, I've seen this, another guy from England on the internet, he can move both sides of the tongue and even pick up a pencil with both sides of the tongue as hands, I guess. Sometimes we've had people who haven't had one of these barbells in for years, and the fistula is still there. You could put a gutta percha point right through it. Maybe these are people that developed that epithelial lining. We don't know. We haven't biopsied them, but that does happen as well. And then these lip barbels or rings and various baubles produce this problem here. They can very seldom cause chipping of the incisal edges. Most of the problem is to the gingival tissues right here. And they develop this habit of kind of pressing against it when they're thinking or watching TV or something, and that just aggravates the problem. And here's another one of those. One of the things I'll show you in a little bit, of course, this can happen from poor occlusion, food just constantly being sluiced down to that site. But one of the things we discovered because of C.D. Johnson's BS factor, if you find any keratosis right here, this is a favorite place for people to put their crack and cocaine. So if you get a buildup of like a leukoplakia or frictional keratosis along with that diastema, that is a sign of cocaine use. If you don't have that, you can still get it if somebody's rubbing this thing against the tissues, but most of the time there is no frictional keratosis. And there's inflammation, whereas the crack cocaine situation is very little inflammatory response. It looks almost like a bisphosphonate osteonecrosis. The soft tissue is almost not inflamed at all. And of course, there are different kinds of jewelries in all other parts of the face. There is something that's still part of the drug culture, especially the injectable drugs, heroin in particular, and that is because of mostly sharing, each other as well as the needles. There's a fair amount, very high proportion of AIDS and HIV positivity in that population. So Candida and, this is atrophic Candida. This has Candida as well as this red stuff is Kaposi sarcoma. I should tell you, we've got the largest AIDS clinic, dental clinic in America, in Houston. It's a private clinic. And they haven't seen a Kaposi sarcoma in at least 5 years there. And we talk about this at our national meetings. We don't know what happened to that disease. It just went away. Even though we've been diagnosing a lot of HIV people who are obviously not being treated yet. We're the ones who make the initial diagnosis. So it's not that the treatment is eliminating it, which it does. The treatment is very good for this disease, that part of the disease. There seem to be, in the drug culture as well as the gang culture, a lot of funny jewelry. This one was not even made by a dentist, but it's really good. And this is what happens. We've seen it more and more with meth mouth because the teeth are so ugly looking and they're just stumps. And I've been amazed at meth mouth. We have yet to see somebody with meth mouth that had an abscess. I don't know why we don't get exposure to the pulp a lot more than we do, but nevertheless, that seems to be our experience. But there are people who are not dentists who can make some bridge work, and this is totally removable. They just put it over the stumps and allow the patient to go on and live their daily life. Here's what it looks like when it's removed. And here is one. This guy actually took it from somebody else. And you can see the plastic is worn off quite a bit, and the occlusion is pretty good. And this is the occlusion I really like. These are all from our clinic. And even with dentures, if people are into a party, I guess, is one way to put it, they like to have a little sparkle on their denture. A little hygiene would help, but sparkle is better. Well, there are sort of generic things that come from drug abuse. People who are heavily into a drug, who are addicted, could care less. You know that. They could care less about their oral hygiene. I mean, they could care less about taking a bath. It's just not, they could care less about eating the proper foods. That's just the way of life. They're worried about, as part of the definition, they're worried about where they're going to get their drug next. They're not worried about taking care of their body right now. So there is a lot of drug neglect. And if you go on the internet, if we had had the room open, I had a series of sort of vignettes off of the internet. People talk to each other and really get pretty specific about problems, mouth problems with their drugs. And I was just going to have that slowly scroll through so people could read them. But One of the questions that seems pretty common if you're a cocaine addict is, what's it doing to my teeth? Everybody knows about meth mouth now, not just dentists. Anybody who's into addiction knows about it. And if you're on methamphetamine, you're probably hanging around with cocaine users. That's just the way it works. Those two drug users seem to like each other. And so the cocaine users see a lot of meth mouth themselves. But this is routine caries. This takes 3-4 years to get to this point. It is cervical in nature, but it's not the same as meth mouth. I'll show you meth mouth in a little bit. I'm sure you've all seen a bit of it. And some of the problems that can happen if you have an addiction in a child, and we have had at least probably 25, 30 people come in who are less than 5 years of age, and they were addicted because their parents were feeding them the drugs. But if that's the case, then you end up with Turner's tooth because you're going to have problems as the baby teeth get carious. They're going to put abscesses around their permanent teeth. But that has to be a pretty early on thing. Now, most of the time, at least in our experience, people who are really addicted to various street drugs, they could care less, as I mentioned, about their oral hygiene. There are some people who don't want anybody to know that they've got a mouth problem, and they worry about their teeth really breaking down. And so they brush like crazy, but they're using these hard brushes. They don't really know that soft brushing is better for you. So this is actually somebody who was brushing you can see the strokes of the brush. They're actually in this, I think it's a gold foil. Maybe not. Maybe it's it's gold anyway. And it's a patient I saw a long, long time ago, so I don't remember. But you can see the grooves in the gold as well. And, of course, I think we've all seen this kind of toothbrush abrasion going on. So there are those two factors, but I'd say for every one like this, you'll see 100 like the previous ones. There are whole lectures. I've given half-day seminars on the problems in the mouth with tobacco use and tobacco products, and most of that has to do with precancers and cancers, and I'll talk a little bit about that next time. But at least I wanted to put it in here so that you have that in mind. We have a lot of systemic problems associated with this. If you look at the charts that show problems associated with, or at least presumed to be associated with chronic tobacco use, you don't find oral problems here at all. Maybe other cancers would be the biggest part of it. We see a lot of very hairy tongues in tobacco smokers. We see a lot of coated tongues. We see a lot of tonsillitis, chronic tonsillitis in smokers. We see a lot of large lymphoid tags, tonsil tags in the throat and soft palate. And we see, of course, leukoplakia as part of that whole business. But I think smoking is the problems involved with the mouth relative to smoking are problems that you're familiar with, so I won't be saying much about this. We'll talk next hour about leukoplakia. At that point, I think I've got this picture in there too, but I just wanted to point out that we know now from actually Dr. Pinborg, the guy I studied with in Denmark, he's the one that said leukoplakia starts very thin, it gets thick, and it gets cracked because of the thickness. And then you start to get this rough surface change, granular leukoplakia, I call it. And eventually you reach a point where the cells are so immature that they can't even make keratin. And so that's the worst place. And it's nice to know this pattern because you know that you want to get the worst place possible for your biopsy. So this is available on the Bouquot to Go disc as well. I drew that. I was coming back from giving the talk on that in France, in Nice, France. I was on the very last plane that Pan Am ever flew. There were 6 passengers on a 747. 18 crew members? I mean, we could have whatever we wanted on that plane. And I wanted a board because I was drawing and taping these tablets together. And believe it or not, they came up with an 8-foot-long board on a 747. And they use it if somebody has a heart attack or faints, they can put them on this board and bring them down the aisle. Smokeless tobacco, when we first started to worry about that and the mouth effects of this in the mid-'80s, that was something that everybody got religion. It was like you could not use smokeless tobacco. It's going to kill you. There were people in the journals like the New England Journal of Medicine saying that we're going to have an epidemic of oral cancer because all these young college kids are chewing tobacco. And I was a dental director for the state of West Virginia at that point. I had already left the university, well, not at that point, but in the mid-'90s. And I didn't see a lot of oral cancer in West Virginia. So when I became the dental director, I had direct access to a really good tumor registry, cancer registry. And I picked up the data and published a paper that showed actually that West Virginia had less of an incidence, a lower incidence of oral cancer than the national average. And you would have thought I was the devil incarnate. People wrote to the governor saying, you've got to fire this man. He's working for the tobacco companies. It was phenomenal. But now, if you go to a lecture on smokeless tobacco use, they're all saying what I was saying 20, 25 years ago. There is an increased risk. And yes, the cancer is probably going to come out of that white patch, but the risk is pretty small. And so we don't worry so much about it. And it is interesting that one of the snuffs that's still available, been around for 140 years, is dental sweet snuff. I got that in Kroger's about 6 years ago. And there are lots of different products on the market. The Swedes have snus, which has no cancer potential. I don't know about the taste of that. Nobody's really talked to me about that. But there is this myth that Copenhagen is the highest risk. And it does have the highest number or proportion of carcinogens. But that hasn't translated into any kind of population study risk. And I was asked to review a paper on this just 6 months ago. And I said, I don't know anything about this. So what I did is I went online. There's nothing in the PubMed. You can't get anything on this in PubMed. But on the online, there are all kinds of places. I found out in Houston there are 14 hookah lounges. And so I went to one of those and said, tell me about what you're doing here. And I had to do this before I could review the paper. It took me maybe 10 hours to get up to snuff, I guess, in order to be able to properly review that paper. And the whole gist of the paper was not that there was any proof that it's a cancer risk, but the gist of the paper was this is something that could be because we've got this tobacco product. And people think if you put the burning tobacco here, actually you put charcoal, and then you put a tinfoil with holes in it, and then you put your tobacco on top of that. And most of the time there's honey mixed with it or different flavoring agents. Marijuana might be what's put on top. Cocaine, some people have said they've used. But they think that because it comes into this water and then you suck it out of the water that it's purified. And this has been tested. And it's pretty much the same smoke that's going into the water. So there's no purification going on with the water system. And I guess we'll just have to wait and see what happens to this stuff. This is a product that there's an argument to whether India started it or Pakistan, but it really wasn't much of a habit until maybe 80 or 90 years ago. It's not one of these ancient habits. So let's talk about marijuana. That's certainly the first of the real street drugs that we'll talk about. And marijuana has lots of street names. Marijuana, as that first that chart indicated early on, people very young can smoke marijuana. It's who knows how they get it, but very young people can smoke marijuana. And the young kids are the ones given all of these names. The average name for a street drug, I don't know who does these studies, but the average name was given by a 16.5-year-old person. That just tells you where these names are coming from. But pot and weed, grass, dope, these are all part of the whole persona. And we can see that if you look at people who smoke at least once a year, these are people who are telling the federal government now that, yes, I'm using marijuana. So who knows what the real numbers are. But 25 users admitted to using it at least once a year. Hookah, by the way, is, I don't think there's much of a problem with that because that's not a daily use type of thing. It's a social thing. You have parties with it, so it would be like binge drinking, a weekend activity. Marijuana can be smoked, chewed, rubbed into the gingival tissues, just like smokeless tobacco. And of course, we know what the main product is. There are lots of different kinds of weeds. I've used marijuana only once, and that was when my brother came back from Vietnam. We went to a cabin in northern Minnesota and shouted at the lake in the middle of the winter and had a good time, actually. But yeah, none of these street drugs have, I mean, each of them have a strong appeal, just like alcohol. People want to feel whatever it is the drug is doing for them. And it just so happens that there's a downside to most of these too. But everybody who is heavily into marijuana realizes that there are a lot of different flavors, just like tobacco. There are some cigarettes that just burn your mouth, and others just make you want to light up another one as soon as you finish. Marijuana is one of the few, cocaine is used this way a little bit, but marijuana more than any other drug, LSD also is used this way. It's put in food. My son was 29 years old. He went to a rock concert in Pittsburgh, and somebody gave him some brownies, a complete stranger. And I would have known better. You don't take brownies from somebody at a rock concert. But they had to, everybody there, they were so high that from just eating this stuff that they had to wait until they came down before they could drive the car home. And nobody was expecting that kind of experience. They didn't know they were even having the marijuana. But it does produce a sense of euphoria. A lot of these do, just like alcohol. It lowers inhibition, so you're a little more free and more party ready. There's a distortion of time and space, which I thought was kind of a neat thing the one time I tried it. And of course, like West Virginia, this is a nice source of income for farmers. So it's got positive things. And right now in this state, it's used as a medicine. And people swear by the fact that, especially chemotherapy patients, it reduces the nausea and the fatigue problems. And there are some papers that say it has a certain level of pain control. So, you know, the jury is out on exactly what the benefits of marijuana are. There are some bad sides. You increase your appetite so much that you're always craving sugar products and carbohydrates, and so we have a little caries problem associated with that. There are dilated pupils that you may pick up because anybody who's heavily addicted is going to use whatever they're addicted to before they come into your office, because they don't want to be in your office and they need a little courage. And I don't know how many of you have had alcohol you can smell in somebody's breath pretty easily. But a heavy alcoholic almost always has to have some kind of alcohol before going to a dental or even a physician's office. You may see red eye, ocular congestion. There are personality changes you may notice over a period of time. My little baby brother went through that kind of a problem because of marijuana. Lots of mood swings from the time somebody gets in the chair. Other street drugs provide larger and faster mood swings. But mood swings are part of it. It you should see the difference, or you can see the difference from the beginning of an appointment to the end of an appointment. This is what marijuana users mostly worry about. They describe it as brain fog. It's like they're only seeing so far with their thinking. And there is a memory loss. Usually it's short-term memory loss that is distorted. But my brother, who hasn't used it in 25 years, he still claims that that's what his short-term memory loss is from. I say my short-term memory loss is just getting old. So this is probably the biggest thing that will cause problems in the oral cavity. There can be, depending on the person, a great loss or depression of the immune system, and Hal talked about that. Bacteria just love to have that kind of thing happen because that opens up a wider field for them. So gingival problems are for a heavy, you have to be pretty heavily into marijuana for gingivitis to get out of hand. But by that point, you're also into this business of I don't care about my teeth. I don't care about my body. I just want marijuana. Of course, it is smoked most of the time, and so pneumonitis and bronchitis are part of that problem. And there are some papers that say that there is an increased lung cancer risk. One paper, I think they estimated it was 4 or 5 times higher than non-marijuana users. And if you look at the carcinogens in marijuana, believe it or not, it's got more than tobacco. It all depends on how it's cured, of course, but there are more carcinogens. So you might hear people say marijuana is worse for leukoplakia and cancers than tobacco. I don't think we have proof of that. I think we just have speculation. People who have come to our clinic talk about burning and stinging. Their whole mouth kind of burns and stings, and I think that's from dryness. The throat can be the same. They get a coated tongue and a hairy tongue as well. There's one paper, and maybe there's a second one that could be taken as legitimate that says there's an increased risk, but that's for oropharyngeal cancer, not for mouth cancer. And oral leukoplakia. I've been in this urgent care clinic for 7.5 years. C.D. Johnson has been looking for 25 years. And this is the only case of leukoplakia we found in a marijuana user. And he claims that he's asked all of the leukoplakia patients, you know, what do you put in there? What kind of habit are you using? So I don't think that's much of a problem. Hashish is a little bit of a different story. This is from the hemp plant. It's just the resin from the hemp plant itself. It produces all the same things in a little higher quantity, and it's not nearly as common a habit. But it is smoked, and so you would expect to get the kind of smoking problems that any tobacco user would have. And there are some systemic problems. Heart rate is probably the biggest, and panic attacks. I don't know how many of you have had a panic attack, but you really can't control yourself when you're in the middle of a panic attack. Alcohol, I'm not going to talk about very much, just maybe 1 minute discussing it because it is one of the most common substance abuses. And if you look in the age group from 10 to 20, it is ranked number 1. You get into the older age groups, and then marijuana becomes the number 1 product. And these are the signs of alcoholism. Much of what we know about addiction comes from alcoholism. All that craving, loss of control, physical dependence is part of this as well. You've all seen, well, we even have a term, DTs, for somebody who's going through withdrawal problems. One of the big problems with alcohol is, as with so many of the other drugs, is you just need more and more of it to get the same level, the same high. And there is no cure for alcoholism. They think that there's no real cure for any of the street drugs if you're addicted. You are always addicted, even if you're not using the product. There is in the mouth something that in oral pathology we've known about for a long time. I can look in somebody's mouth and assume, before I know from questioning them, that they're an alcoholic. Because it is... You get this blotchy, you get little strings, sort of like some alcoholics have on their face, little strings of vascularity, but you get blotchy areas of paler and red areas that are kind of more vascular but don't look as if they've got blood vessels on the surface. And it just looks like if you touch that, it would break down. And we call that alcoholic mucositis or alcoholic mucosa. Those of us in the business of seeing a lot of patients recognize it. The only other thing that could do this would be a severe nutritional deficiency, a strong anemia, for example. And that could be part of an alcoholic problem or any addiction. There are a few people who will present with their jaundice first in the mouth. Here's one. This was one of my neighbors, actually. This was a perfectly yellow soft palate, a little bit of yellow soft palate here. But I want to, oh no, I'm sorry, this I put in as a differential diagnosis. This is on the hard palate. You see the molars go behind this yellow area. Some people have a yellow, very thick fat pad on the hard palate. That does not extend onto the soft palate. So if you see yellow of the soft palate, you think one disease. You see yellow of the hard palate, you think variation of normal. They just have more fat near the surface. And, yeah. Yes, actually I had something under the tongue. Ventral tongue and a little bit on the oral floor are 2 other places that I've seen jaundice there with no evidence of jaundice on the skin yet. But of course the key to jaundice is the yellow eye. Nothing else will make eyes yellow but jaundice. And of course that's cirrhosis. I want to point out, fatty liver is not alcoholic cirrhosis. I mentioned I have a fatty liver, but it's not that problem. I did have an interesting, my physician in West Virginia who did the biopsy was trained at the Mayo Clinic and really was a kind of an uptight person. And he did everything to get me to confess that I was a closet alcoholic. And when he didn't find any fibrosis in the liver, he actually apologized. He called my wife to find out, with my permission, to find out if I was drinking a lot at home. And then after the biopsy, it proved not to be alcoholic cirrhosis, and he actually told me, "You can drink as much as you want." He was feeling guilty. Well, if you ask a bunch of dentists, how many people in your practice have some kind of an alcohol or some kind of a drug addiction? Most of them will say it's a small proportion. Some offices, usually in larger cities, have a higher proportion of the patients. And then you ask them, well, what kind of problem do you have? You'd expect the big one is the one that affects the teeth, and that's methamphetamine. I want to point out, however, this is stuff that is just our observation. And so it is very much like this. We don't have any real proof. We're just providing some kind of anecdotal evidence. Roger's law I love. As soon as the stewardess serves coffee, the airline encounters turbulence. And then Davis had an explanation of the law saying serving coffee on an aircraft causes turbulence. We have to always be very, very careful of coming to the wrong conclusions because we don't have all the right information. And if we look at methamphetamine in the mouth, well, these are prescription drugs of amphetamines. And I guess I put this in because I wanted to warn you that this is something that isn't just methamphetamine. There is a very, very strong amphetamine abuse in this country as well. And that does things like give you a very high blood pressure, heart rate, increased respiration, just gets the whole metabolism going a little better. And there are lots of street names. And the more street names you have, the more common you know the drug is. And so amphetamines is part of what the methamphetamine is all about. It's from that whole experience. It is a neurotransmitter, and I'm not going to get into the physiology of all of this. There are 12 million users in this country, at least those who are willing to tell the U.S. government that they are. And this is mostly taken as either a tablet or a powder. There are people who inject methamphetamine into their bloodstream, and those are people who will never get away from their addiction. They literally have to have methamphetamine. And I think I mentioned that there are stories and histories in our published literature that document people who have had one methamphetamine experience, not an IV experience, just a regular methamphetamine experience, and they were hooked from that point on. We don't know what it is in those individuals that make them immediately hooked, but we know that it's there. Most of the time, or a lot of the times, I should say, is it's smoked, and this is the reason. You can have a high for maybe up to a day. You feel great for a whole day. And it does, well, I wasn't going to get into the physiology, so I won't get into that. But I did want to point out, it increases dopamine levels because it blocks the dopamine uptake. But that means that dopamine levels can build up, and dopamine, I didn't know this till I got into this whole topic, if they reach a high enough level, normal dopamine production, if it reaches a high enough level, is in fact neurotoxin, and you can get brain or neural damage from dopamine levels. Methamphetamine, this is that one gal I talked to you about. Methamphetamine produces meth mouth. It also produces a very volatile personality, everything. As much as heroin, methamphetamine becomes everything in these people's lives. I know at least 3 people in my extended family who have gotten so into meth that they had to sell it, make it and sell it. And therein lies the problem. There's no quality control in methamphetamine production. And because of that, I've had people go from, well, I'll show you in a little bit, from relatively normal mouths to stumps, black stumps in 9 months. That's how fast this stuff can move. And I'm sure it's because of the quality control issue. I mean, battery acid, sulfuric acid, is used in many of these labs. Anybody can set up a meth lab. The Indonesians have really done it big time. That's where most of the real commercial grade stuff is, and that might be a good thing because it's quality controlled. But most methamphetamine is in somebody's garage. And every once in a while you hear a story about a college room in a dorm that got blown up because a meth lab blew up. And but look what it takes. It doesn't take anything fancy, the products, in order to make this stuff. And look what's in it. I told you about sulfuric acid. Oh, drain cleaners is another good source of that. Red phosphorus, breaking up matches. Lithium is not a very a weak product. We also have, what is it? Well, the alcohol. Well, at any rate, I think what is in methamphetamine is going to be the impurities. I think that is what is producing most of the carries. There's a huge munchie craving, the sugar craving, very strong, probably more than any of the other drugs. A very strong craving for sweets and sweet carbohydrates. And you add that to a product that has a very low pH because it wasn't well made, and it has a lot of impurities, including natural sulfuric acid. I mean, if you took a tooth and put it in sulfuric acid, how long would it last? Maybe 2 hours at the most. And we've seen meth mouth with, I've seen it in all colors, and I think it has to do with the impurities. The impurities, I've seen purple teeth with meth mouth, I've seen orange, I've seen red, I've seen blue, and it's got to be the impurities. Whoever is making the meth for those people has some product in there that's making those colors. And this is something the feds really hit the meth labs very hard in 2004. They started a campaign. And now this, in 2006, it went from 18,000 meth labs in the country, at least those that were seized. These are the ones that law enforcement knew about, down to 6,000. And last I heard it was closer to 5,000 now. Little story. I'll talk about a few of the others when we get into the next session. But there was a story about 3 years ago. A town in North Dakota was shut down, about 200, 300 homes, no, 400 homes, because they were downwind from a large open pit mine that had polluted the ground all around them. And people were getting sick, so the feds and the state government and the company that did it literally just moved the town away. They put a fence around the town. Within 9 months, there were 120 meth labs in that town. So if you don't think this is big business, word gets around very fast. Hey, we got a place over there with no cops and all these houses that are in good shape. And they didn't apparently care about whether they were being exposed to, I think it was copper. Well, there are lots of ways to smoke this, but their meth pipes are really funny-looking pipes. You can burn the methamphetamine, make a crystal and a liquid that is put in a pipe, and then they have these large. I've tried one. It doesn't suck very well. It's just too large an opening, but that seems to be what the meth pipes are all about. I don't know if you saw this. This was sort of national news about 3 months ago. Charlie Sheen, one of his prostitutes, said that he's got implants. He has no natural teeth because his teeth were destroyed by meth mouth. I have no idea if it is real, but it is still on the internet, so it's got to have some validity, right? This is one of the things that people with methamphetamine overdose might actually bring them to the dentist. Very bad breath and a mouth that is very, very dry. I've had one methamphetamine user who was using it all day long, had been using it for 3 or 4 years. His mouth was so dry when I